Welcome to the Deep Dive. Today we're getting into something really critical, health information management. It's complex, high-stakes stuff.
Absolutely. Our goal really is to help you understand how healthcare data gets protected, what happens legally when protection fails, and how that secure data actually helps improve public health overall.
It's like a chain, isn't it? Where do we start? Protection.
Yeah, gotta start there. So, data security. The go-to definition is usually from NIST. Basically, it's all the measures and tools you use to keep data and systems safe.
Safe from what, exactly?
Safe from anyone trying to access, use, change, or even destroy it without authorization, or just, disrupting the system. It's pretty comprehensive.
Okay, so it's not just hackers. It's about keeping the data reliable, too.
Exactly. Which brings us to the foundation.
Mm-hmm.
The CIA triad. You've probably heard of it.
Right. Confidentiality, integrity, availability, standard security stuff, but how does it apply specifically here?
Well, confidentiality is keeping patient data private, obvious, right? Availability means, the system works when you need it, like urgently in the OR.
But integrity, I feel like that's the absolute key in healthcare.
Without a doubt, it's the most crucial. A confidentiality breach, that's a huge privacy violation, massive fines, terrible PR, but a failure of integrity.
That's patient safety on the line.
Precisely. Data that's wrong, incomplete, out of date, that leads to misdiagnosis, wrong meds, potentially fatal errors. Integrity means the data is complete, accurate, consistent, up to date, always.
And the big rule governing all this electronic health info, the EPHI, is the high-pay security rule. What's special about it?
Well, the really smart thing about the high-pay security rule is how flexible it is. It's designed to work for anyone.
Meaning?
It's scalable, so it fits a tiny clinic or a giant hospital network. It's flexible, letting organizations choose measures that fit their own size and complexity. And critically, it's technology neutral.
Ah, so it doesn't say, buy this software.
Exactly. It focuses on the outcome, not the specific tool. It lays out 5 safeguard categories: administrative, physical, technical covering policies, door locks, access controls, you name it.
Okay, fortress built. Conceptually, anyway. Now, the threats. You mentioned 2 kinds, environmental and, well, people.
Yeah, things like floods, power outages, they happen. But honestly, when we're talking electronic data,
That's the human factor.
overwhelmingly, the biggest threat category by far is people. And that's a really broad category.
Okay, let's unpack that. It's not just hackers in hoodies.
Not at all. It
Yeah.
goes from completely unintentional mistakes. Someone clicks a bad link, they're busy, whatever.
Happens all the time.
Right. Then you've got insiders who deliberately abuse their access. Maybe they're mad. Maybe they're trying to sell data for profit.
Oof.
And then, the outsiders, people launching attacks out of revenge or organized groups trying to steal financial info, lock up systems.
Which leads right into social engineering. Sounds technical, but it's really about manipulating people, isn't it?
It's the ultimate workaround for technical defenses. You trick someone into giving up their password or clicking something dangerous.
How does that usually work?
Well, the hacker pretends to be someone trustworthy, maybe someone from IT, HR, a colleague, someone you wouldn't suspect.
And the most common way we see this is phishing, right? Through email.
Yeah, that's the classic mass market approach. You get an email that looks totally legit, an urgent alert, maybe click the link, and bam.
But there are sneakier versions, too.
Oh, yeah. Spear phishing targets specific people, like executives. Baiting leaves infected devices lying around. Tailgating is literally following someone through a secure door. It's all about exploiting human trust or carelessness.
And then there's the actual malicious software, the malware. What
Yeah.
are the big ones in healthcare?
Well, you've got your usual suspects: viruses, worms, spyware. Trojans are bad because they can copy files secretly, but the one keeping hospital CEOs up at night? Ransomware. Locked up everything. Data, systems, unavailable. And since availability is life or death in a hospital, it's a massive threat. They demand money to unlock it.
Just crippling. Okay, before we move off security, what about the everyday internal threat? The employee looking up their neighbor's info. How do you catch that?
That's where audit controls are absolutely key. It's a technical safeguard.
What do?
They automatically log who accessed what record, when, and maybe even what they did in there. So if someone's poking around where they shouldn't be,
There's a trail.
there's a clear trail. It's a huge deterrent.
And simple things help, too, like automatic log-offs, so screens don't stay open.
Exactly. You walk away, it logs off. Prevents casual viewing by visitors or whoever. Security needs layers: physical, technical, administrative.
Okay, so that's the defense. Now, let's talk liability. What happens when those defenses fail or someone just plain messes up? We're in the lawsuits now.
Right. We move from security rules to legal consequences. The big one is negligence. That's the basis for most medical malpractice claims. It's considered an unintentional tort, meaning you didn't mean to cause harm, but you did through carelessness.
And to win a negligence case, the patient, the plaintiff, has to prove 4 specific things.
4 elements, yes. Fail on anyone, and the case collapses. First is duty.
Meaning the doctor or hospital actually had a responsibility to the patient.
Yep. A legal obligation, usually straightforward in healthcare. Second, breach.
They violated that duty, didn't meet the standard of care.
Exactly. This is where maybe a security failure or using inaccurate data comes into play as evidence. They didn't do what a reasonable professional would have done.
Okay, duty, breach, then causation. This one sounds trickier.
It often is. Also called proximate cause. You have to prove the breach directly caused the injury.
So not just the record was wrong, but the doctor used that wrong allergy info, gave a drug, and that caused the bad reaction.
Precisely that link. The breach led directly to the harm. And fourth, damages.
Actual harm happened. Medical bills, lost work, pain, and suffering. Stuff you can put a dollar amount on.
Right. There has to be actual provable harm that warrants compensation.
Now, what if it's not unintentional? What if someone does something deliberately wrong, maybe even illegal?
Now you're talking about malfeasance. That's performing a wrong or improper act. It's a higher level of wrongdoing than just carelessness.
Okay, so the potential damages, the legal costs, they can be huge. Which explains why we hear about settlements, right? Like that case where a hospital paid $4 million.
Exactly. Why settle for such a huge amount? It's risk management.
Avoiding a trial.
Avoiding a jury, specifically. A settlement means no formal finding of malpractice, which is good for PR, but the big reason is juries are unpredictable.
Especially with non-economic damages, pain and suffering.
Right. Juries can be swayed by emotion and award massive unexpected amounts for that. The $4 million settlement, while huge, buys certainty. It avoids the risk of a jury hitting them with, say, $15 million.
Makes sense. Okay, shifting from civil liability to fraud against the government, the False Claims Act, or FCA.
A very powerful federal law. It basically says you can't submit false bills to government programs, primarily Medicare and Medicaid and healthcare.
And it has this unique feature for whistleblowers.
It does, the quid tam provisions. It's Latin, meaning who sues for the king as well as for himself. It allows a private citizen, usually an employee who sees the fraud, to sue the offenders on behalf of the government.
Wow, so the employee becomes a sort of temporary government agent.
In a way, yeah. They bring the lawsuit, the government can join in, and if they win,
What are the penalties?
they are severe, designed to really hurt. Trouble, damages. 3 times the amount the government actually lost due to the fraud. Plus, hefty fines for every single false claim submitted.
Whoa, so if you defraud Medicare of $1 million,
You could end up paying back $3 million, plus potentially hundreds of thousands in fines based on the number of bogus bills. It shows why healthcare compliance programs are such a big deal. The risk is enormous.
okay, we've covered protecting the data and the serious fallout when we don't. Why all this effort? It's not just for treating the individual patient, right?
Correct. That's primary data. Use the health record for direct care. But all that carefully protected, high-integrity data has immense value for secondary use.
Secondary data, meaning
Data pulled from those primary records for other big-picture purposes. Think research, tracking quality of care, public health surveillance, planning where to put resources. It's vital for understanding the health system.
what are some key sources of this secondary data?
Well, a big one is registries. These are collections focused on specific things, diseases like cancer or diabetes, conditions like trauma, even medical devices or implants.
And transplant registries, too.
Yep, the Organ Procurement and Transplantation Network, OPTN, maintains those. Very important. Then you have vital statistics.
Births, deaths, marriages, that kind of stuff, kept by government agencies.
Exactly. Crucial for tracking population health trends. And with death data, for instance, it's important to know the difference between the immediate cause of death.
Like heart failure.
Right. And the underlying cause, the condition that actually started the whole chain of events leading to death, that underlying cause is what's used for public health statistics.
Beyond registries and vital stats, there are massive databases too.
Oh, yeah. Things like MedPAR, huge amounts of data on Medicare patients in hospitals and nursing facilities, and HCUP, the Healthcare Cost and Utilization Project.
That includes the National Inpatient Sample.
Right, the NIS. It's the biggest publicly available inpatient care database covering all payers, not just Medicare. Lets researchers see patterns across the whole country.
Okay, one more database, connecting back to accountability, the National Practitioner Data Bank, the NPDB,
Ah, yes, the NPDB. This ties directly into ensuring quality providers, doctors, nurses, others. They have to go through credentialing.
which is verifying their qualifications, education, license.
And critically, their malpractice history. That's where the NPDB comes in. It was set up by law in 1986.
What's in it?
It's a confidential repository of information on medical malpractice payments and certain adverse actions like license revocations or suspensions against healthcare practitioners.
And hospitals have to check it.
They are legally required to query the MPDB when a practitioner applies for privileges. That's initial credentialing, and then again at least every 2 years for recredentialing.
So it stops providers with problems from just moving state to state unnoticed.
That's the idea. It's a crucial safety check. But important note, the general public can't access the NPDB. It's for healthcare entities, licensing boards, etc.
Got it. So all these secondary uses, research, registries, quality checks, credentialing, they all depend on one thing, right?
Absolutely. They depend entirely on data integrity, the very first thing we talked about with the CIA triad.
If the original patient record is inaccurate or incomplete,
Then the secondary data derived from it is useless, or worse, misleading. Garbage in, garbage out. Data quality dimensions like accuracy, completeness, consistency across different sources, timeliness, validity, they are paramount.
so it all connects. Good security practices, like the CIA triad, ensure data integrity. That reduces legal liability.
Yeah.
And that high-quality, reliable data then fuels all these vital secondary uses for public health and quality improvement, like the MPDB.
It's a virtuous cycle when it works properly.
Okay, as we wrap up this deep dive, let's land on a really interesting tension here. Our sources indicate that, for risk management, organizations should systematically destroy old health records after the legal retention period.
Right. From purely an administrative and security view, less data means less risk if there's a breach and lower storage costs. Destroying it makes sense.
But patients have rights to their own information. California law was mentioned, requiring providers to give patients 60 days notice before destroying their record.
Yeah, it highlights a real conflict. The organization's need for efficiency and risk reduction versus the patient's right to access, maybe even retrieve, their own medical history.
Which brings us to our final thought for you, our listener. How do we strike the right balance? How do we manage the very real need to dispose of old records to limit risk and cost, while also upholding the ethical and sometimes legal duty to empower patients by giving them a fair chance to get their history before it disappears forever?
That's a fundamental challenge in health information management today. Definitely something to think about. Thanks for joining us.
We'll catch you on the next deep dive.